Hi, my name is Beukema, and this is my presentation about my quality improvement project that aimed to reduce substance use stigmatization by healthcare workers towards patients with substance use disorders. This is my capstone project for my doctorate of nursing practice degree at Maryville University. The chairperson for this project was Dr. Diane Ferris, and the second reader of this project is Dr. Maurice Snell. Both are faculty members at Maryville University in St. Louis. My community member is Dr. Ryan Wang, who is a practicing psychiatrist on an inpatient unit in San Diego. As many healthcare professionals know, many of our patients present with comorbid substance use disorders. The Centers for Disease Control and Prevention estimates that at least 48.5 million Americans either use substances recreationally or misuse prescription medications. Substance use creates a tremendous burden to society, as the latest data from the CDC indicates that during the 12 months preceding April 2021, over 100,000 people have died as a direct result of substance use, which represents an increase of 28.5% compared to the same period over the year prior. And of these deaths, opioids are by far the primary cause, as they are responsible for over 75,000 of these deaths, which is a 35% increase compared to the same period the year before. Substance use-related mortality has been a significant problem for several decades. In 2007, the rate of substance abuse-related deaths was estimated to be 12.6 per 100,000, which prompted the Healthy People 2020 initiative to set a national healthcare goal to reduce this rate by a modest 10% to 11.3 deaths per 100,000 by 2020. Overall, the healthcare community and society at large have failed to meet this goal, as the substance use-related death rate has since more than doubled to 28.3 per 100,000 in 2020. And finally, besides the tragic loss of life, the annual healthcare costs associated with substance use disorders are estimated to be over $13 billion, and the societal and economic burden associated with substance use, morbidity, and mortality is undoubtedly many times larger than this figure. As we will see, stigma by healthcare workers towards patients with substance use disorders plays a significant role in both the health-seeking behaviors as well as the quality of care outcomes that patients receive. This stigma appears to be pervasive and systematic, as a significant number of patients have reported that they feel judged or have been marginalized by healthcare workers due to their substance use disorder in some way. Additionally, even a significant portion of healthcare workers have self-reported having these stigmatic attitudes towards their patients with substance use disorders. Unfortunately, the presence of the stigma is reported across nearly all healthcare specialties and professional roles. Moreover, patients with substance use disorders are less likely to receive quality, safe, and equitable care when they seek care. Not only goes this against established healthcare standards and expectations, but it's also very often contrary to ethical guidelines established by various professional organizations and boards. Thus, quality improvement interventions such as this project that attempt to address this stigma through translational research are important in improving the care that patients with substance use disorders receive, and to help healthcare workers encourage health-promoting behaviors from their patients. The literature review that was conducted yielded three overall themes that were pertinent to this project. First were the consequences of stigma. Prior research has shown that patients who are perceived being stigmatized have poorer therapeutic relationships with their healthcare professionals, which leads to dishonesty regarding their substance use and the minimization of their symptoms. Additionally, some patients have reported that negative attitudes by healthcare workers have led them to engage in more confrontational and antagonistic behaviors towards healthcare professionals, which we will see shortly further contributes to the stigma. Overall, these patients engage in less health-seeking behaviors, which often causes them to present sicker when they do eventually seek care. When these patients do receive care, it is often of lower quality, such as patients not receiving required referrals, not being prescribed proper medications, or the overtreatment of their overdoses, or the undertreatment of their withdrawals. All these factors contribute to overall poorer health outcomes for patients with substance use disorders. The second theme that emerged from the literature review pertains to the cause of stigma by healthcare workers towards their patients with substance use disorders. As mentioned on the prior slide, a significant portion of healthcare workers report compassion fatigue and burnout related to negative encounters that they have had with patients that had comorbid substance use disorders, as many of these encounters have often been anxiety-inducing, emotionally draining, or sometimes violent. And this compassion fatigue has been found to be a significant driver for stigma. Thus, one can easily recognize that this relationship between stigma and negative patient encounters creates a self-reinforcing negative loop. The presence of this self-reinforcing loop seems to be validated by research that indicates that the more years of clinical exposure to patients with substance use disorders, the higher healthcare workers score on self-reported stigma instruments. The only notable exception to this are healthcare workers who work in psychiatry and substance use treatment. And finally, contributing to worsening stigma is knowledge deficits about substance use disorders and addiction among healthcare professionals. as years of clinical experience does not necessarily translate into increased knowledge by healthcare workers, which also contributes to patients' perceptions regarding the quality of care that they are receiving. The third and final theme that emerged from the literature review is that educational interventions were found to be effective in reducing stigma by a majority of the researchers. Additionally, it was found that many healthcare workers themselves recognize the potential benefits of education. Educational topics that were included in prior research that resulted in decreased stigma were addiction physiology, the biological and socioeconomic factors influencing substance use, and treatment approaches and guidelines for substance use disorders. Furthermore, healthcare workers reported their educational preferences to be handouts, PowerPoint presentations, and on-the-job in-services. However, this preference for shorter education is also where a major gap in the prior research exists. Nearly all educational interventions showed an improvement in stigma, but these interventions were anywhere from 4 hours to several months in length. Lengthy education is not a sustainable and economic, thus realistic, approach in addressing this already existing problem. Additionally, no validated curriculum is currently available. This project does aim to contribute knowledge regarding the use of short-duration education as a method to decrease stigma, and to provide additional insights into effective curriculum topics. The theory of reasoned action was developed to explain the relationship between attitudes and behaviors. It postulates that if a person views a behavior as positive and they think that others want them to perform the behavior, it increases the likelihood of a person to perform the behavior. The theory of reasoned action model assumes that behaviors are under volitional control of the person and that intention is both the immediate determinant as well as the best predictor of the behavior occurring. Intention under this model is based on two further determinants: what the attitude towards behavior is and the subjective norms surrounding the behavior, i.e. what the person perceives others' expectations regarding the behavior to be. This project aims to address these two aspects of intention. First, the aim of the brief educational intervention is to shift participants' attitude and factual beliefs regarding substance use disorders. And second, through increased education, healthcare workers will start to have a greater number of colleagues that have a better understanding of substance use disorders. And this hopefully translates into an environment in which improved attitudes towards patients with substance use disorders can be fostered and sustained. To evaluate the effectiveness of this quality improvement educational intervention, quantitative research techniques were used to assess participants' self-reported stigma prior to the intervention as well as 4 weeks later. This project had to utilize a quasi-experimental approach due to the design not being conducive to the randomization of participants, nor was it possible to include a control group. As discussed in the literature review, no validated short-format substance use curriculum that reduced stigma was found. This was thus developed specifically for this project and incorporated topics that had been shown to be effective. The final intervention was presented by this project's principal researcher over approximately 20 minutes utilizing PowerPoint slides that contained information on the biological and psychosocial factors of addiction, common patient presentations of substance use disorders, and substance use disorder treatment approaches and considerations. The content of the final presentation was reviewed for accuracy and approved by the facility's nursing educator, as well as a practicing board-certified psychiatrist, and was approved as part of the final project design by the institutional review boards of both the facility and Maryville University. The project was implemented at a large Level 1 university-affiliated hospital in Phoenix, Arizona. A total of 6 in-service sessions were scheduled for 30 minutes each. This allowed 10 minutes for the completion of the pre-intervention surveys and 20 minutes for the presentation of the priorly described educational intervention. Sessions were scheduled across multiple days and covered both day and night shift to maximize attendance opportunities by interested staff members. The population of interest were healthcare workers, including registered nurses and ancillary patient care staff, such as certified nursing assistants, behavioral health technicians, and patient care assistants, that provided direct patient care as part of their primary job function. Furthermore, 2 hospital units participated with this project, the inpatient psychiatric unit and the general medical surgical unit. Interested staff members were invited for voluntary participation utilizing convenient sampling, informational flyers containing information on stigma and substance use disorders, and the available session times were posted in staff-only areas on both units. An electronic version of this flyer as well as reminders were sent out by nursing managers on both units. 2 data collection tools were used to evaluate the outcomes of this quality improvement project. The first tool was a basic demographic survey that collected information on participants' practice specialty, practice role, whether they provided direct patient care as part of their primary duties, their age within a 10-year range, and how long within a 5-year range a participant had been practicing within their role. The second data gathering instrument that was used was the Drug and Drug Problems Perception Questionnaire. This is an instrument that was designed to measure healthcare worker self-reported stigma and therapeutic commitment towards patients with substance use disorders along 5 subscales. These 5 subscales include role adequacy, role support, job satisfaction, role-specific self-esteem, and role legitimacy. This tool has been demonstrated to be both valid and reliable when used with healthcare workers to assess for substance use disorder-associated stigma. And finally, all survey data was collected utilizing a web-based survey that was available during the week of the intervention. The 6 in-services were scheduled during the second week of November 2021. Prior to being presented with the intervention, participants provided implied consent and completed the demographic survey, the Drug and Drug Problems Perceptions Questionnaire, and provided the self-generated matching variable that allowed pre- and post-survey responses to be matched. 4 weeks after the initial survey, during the second week of December in 2021, participants were reminded by nursing management to complete the follow-up survey that contained the Drug and Drug Problems Perceptions Questionnaire, as well as the self-generated matching variable. Descriptive statistics, including frequencies, averages, and standard deviation, were used to describe the demographic survey data, as well as the Drug and Drug Problems Perception Questionnaire subscale scores. Due to the small sample size of only 16 paired samples, the collected data did not meet the normality of distribution requirements. Therefore, non-parametric statistics were calculated utilizing the Wilcoxon-signed rank test. The independent variable was a 2-level pre- and post-education categorical variable, and the dependent variables were the average scores on the 5 subscales of the self-reported Drug and Drug Problems Perception Questionnaire. All data analysis was performed utilizing the 27th version of the statistical package for the social sciences, also known as SPSS, and through consultation with Maryville University statistician.
The demographic survey yielded the following descriptive information regarding the 16 participants. 8 participants worked on the medical surgical unit and 8 worked on the mental health unit. 12 of the participants identified their role as a registered nurse, while the remaining 4 identified themselves as being employed within the ancillary patient care role. As far as the age distribution goes, none of the participants were aged between the age of 18 and 19. 3 participants were between 20 and 29 years of age. 5 participants were aged between 30 and 39. 5 participants reported their age between 40 and 49. 2 participants were aged between 50 and 59, and 1 participant was over the age of 60. And finally, the data regarding the number of years that participants practiced within their role was as follows. 4 participants reported being active within their role between 0 and 4 years. 3 participants reported being in their role between 5 and 9 years. 4 of the participants reported being in their role between 10 and 14 years. 2 of the participants had been in their role between 15 and 19 years. And the remaining 3 participants reported being active within their role for over 20 years. Wilcoxon-signed rank analysis of the pre- and post-education survey results revealed that there was no statistically significant difference between the scores on any of the 5 Drug and Drug Problems Perception Questionnaire subscales. This pertained to an analysis of all participants as an aggregate, as well as an analysis of the survey results based on participants' practice specialty, as shown in this table. However, when the pre- and post-education subscale scores were plotted based on participants' practice specialty, as shown in this graph, a difference between the specialty groups did become apparent, which prompted the additional statistical analysis based on pre-education scores to be done as well, which revealed that healthcare workers within the psychiatric specialty scored significantly lower on two of the 5 Drug and Drug Problems Perceptions Questionnaire subscales, namely job satisfaction and role support. These results indicate that the respondents from the psychiatric unit reported that they felt they received more support from their colleagues and overall derived a higher sense of satisfaction from their work with patients with substance use disorders compared to the respondents from the medical surgical unit. Some limitations were evident with this project. The first ones are related to the design of the educational intervention. As no prior existing and validated brief format substance use disorder curriculums aimed at healthcare workers existed, the educational content had to be developed by this project's primary researcher, who has no prior professional or formal educational background in curriculum design. Additionally, the intervention did not account for potential learning disabilities, it failed to consider participants' primary language being anything besides English, and the content assumed that participants' literacy level was above a 12th grade education. The second limitation pertained to the data collection methods. Firstly, this project utilized convenience sampling. This sampling method likely contributed to a volunteer bias as participants self-selected for participation and thus likely did not adequately represent the general population of healthcare workers at the facility. It stands to reason that the final sample of participants presented with higher prior interest in the topic of substance use disorders exhibited lower stigmatic attitudes at baseline and were overall less likely to derive benefit from additional education that this project provided. Additional biases that could have affected the outcomes of this project were the social desirability response bias, which made it more likely that participants represented themselves congruent to social norms, such as reporting their stigma to be lower than in actuality. Secondly, the utilization of 7-point Likert scale on the drug and drug problem perception questionnaire lent itself to extreme response bias, where a response of strongly disagree or strongly agree would not necessarily signify the most intense feeling, but rather attempt to capture the trait of the respondent. And lastly, this project's small sample size was also a major limitation. As noted before, convenient sampling likely contributed to the relative small sample size that was obtained. A larger sample size would have added more strength and validity to this project's results. However, due to these limitations, generalizations about this project's outcomes pertaining to healthcare worker stigma towards substance use disorders are impossible, and the outcomes can only be discussed in relation to those healthcare workers who contributed to this project's results. While this project failed to demonstrate statistical effect on the reduction of stigma using an educational intervention aimed at healthcare workers, some implications to nursing practice and healthcare were highlighted. With regards to nursing practice, the literature review suggests that stigma directed at substance use disorders by healthcare workers continues to contribute to significant worse patient outcomes, that this problem is becoming more pressing and dire as substance use disorders represent an increasing problem to both healthcare and society, and that realistic and economical solutions are needed, but that these remain scarce. Because of this, healthcare workers should be encouraged to take initiative to improve their own practice and to seek out additional knowledge through continuing education opportunities, as increased knowledge about substance use disorders has been shown to decrease associated stigma. Due to the wide scope by which healthcare is provided, as well as the pervasiveness of stigma towards substance use disorders, it is unrealistic to assume that changes within a limited number of organizations would significantly contribute to any systematic improvements in the quality of care that is provided to patients with substance use disorders. Thus, further recommendations are aimed at systemic policies. Rapid improvements in the knowledge about substance use disorders amongst healthcare workers, and thus the quality of care that's provided to these patients that have substance use disorders, could be achieved by various policymakers through mandates that would require healthcare organizations to include employee training requirements on the topics of substance use disorders. An additional opportunity for policy change can be found within organizations and governmental departments that determine educational requirements for newly graduated healthcare workers, such as state nursing boards. Through the intervention at this level, educational institutions can be mandated to alter existing educational curriculums to emphasize the impact and treatment considerations associated with substance use disorders. While changes at this level would not address the existing problem of substance use disorder-associated stigma, it would ensure that future generations of healthcare workers receive adequate training on the impact that substance use disorders have on their own practice, as well as the overall provision of care. In conclusion, this quality improvement project aimed to provide support and confirmation for the efficacy of short-duration education as a viable tool to address the problem of stigma. The intervention that was used for this project was designed by this project's primary researcher and was implemented on 2 participating units, a psychiatric and a general medical surgical unit at a large urban hospital in Phoenix, Arizona, towards the end of 2021. The total length of the education was kept around 20 minutes to ensure that future implementation and potential use by the hosting facility would be both economical and practical. The content was based on prior research findings that had identified potential educational topics that had shown to potentially contribute to lower stigma by healthcare workers towards substance use disorders. After final analysis, the results from the 16 respondents failed to show that this project's intervention produced a significant outcome. Additionally, due to the limitations pertaining to this project, these outcomes cannot be generalized beyond the sample of participants who completed the pre- and post-education surveys that were spaced 4 weeks apart. However, the results from the pre-education surveys did indicate that healthcare workers who worked on the psychiatric unit reported receiving better support from their colleagues, and additionally reported a higher level of satisfaction when working with substance use disorder-afflicted patients. This outcome was expected as prior research had already reported similar demographically associated findings. While this project was unable to demonstrate a statistical effect, prior research highlighted that substance use disorder-focused education aimed at healthcare workers is a viable approach to lower the degree of exhibited substance use disorder-associated stigma. And since education remains the most realistic and viable approach to improve knowledge and healthcare worker comfort when it comes to working with patients diagnosed with substance use disorders, it should remain the focus of continued research.
This project offered two potential areas of future research: the need for improved knowledge that delineates healthcare workers' knowledge and stigma in relation to the overall length of the provided education. And additionally, there is a need to identify which curriculum topics yield the highest impact on overall knowledge and contribute to a decrease in self-reported stigma. It would further be prudent to maintain focus on interventions aimed at individual healthcare workers, as the overall quality of care that patients receive is a cumulative reflection of the individual care that each healthcare worker provides. This concludes the formal results of this project. However, I would like to also share some personal impacts that this project has had. I initially chose this problem as I noticed certain attitudes and comments of my coworkers when I was working as a bedside nurse, and I wanted to understand this problem at a deeper level. I think most people that work in mental health can attest to the sheer number of patients with comorbid substance use problems, and I wanted to deep dive into this problem as this is a population that I both enjoy working with as well as intend to work with once I finish my education. So while this project may have failed to make a meaningful difference, it did hugely impact my own understanding of this problem and will undoubtedly make me a better and more understanding provider. Currently, I do not have any intention to formally continue doing research, but I would be interested in participating with quality improvement initiatives at whatever place I end up practicing. And the knowledge that I gained through the formulation, design, implementation, and evaluation of this project will undoubtedly help me to contribute meaningfully to this cause. I want to thank you for taking your time to listen to this presentation on my project that aimed to use a brief educational intervention to reduce stigma that healthcare workers have been shown to exhibit to their patients with substance use disorder. I now would like to give anyone the opportunity to ask any questions and provide any feedback on this project.